So, good day, classmates and Ma'am Alundra. This is our report about attraction, romance, and sexual intimacies with clients and subordinates. So, the first question that will pop out about this topic is that is having sex with clients helpful? So, excuse me. Three licensed psychologists with solid credentials argued that sexual intimacies with clients was creative and boasted about their successes. Clients they believe benefited most were typically vulnerable, inexperienced, sexually inhibited, fearful of intimate relationships, experiencing low self-esteem, suffering from adversive experiences in childhood, and distrustful of men. So by today's standards, think easy targets. These clients were also described without exception as younger women. So we have here sexual attraction. Therapists attracted to clients. So of the 95% of the male therapists and 76% of the female therapists admitting feeling attracted to at least one client, the majority felt guilty, anxious, or confused. Older female therapists were less likely to report ever being attracted to a client, whereas the attraction rate for younger female therapists approach that of female therapists. So next. So we have here a sample case. So you can read it. You can pause our presentation and read this. The explanation here is that Dr. Fixit may have meant well in his own mind. However, his actions illustrate insensitivities and cultural bias. He focused on physical attributes of the client and clearly asserted white privilege, with an implication that attraction to people of Asian ancestry holds less value. Most therapists would not attempt to alter a client's self-perceptions without first attempting to understand the basis for the feelings. So, next. Client attracted to therapists. So, clients sometimes become sexually attracted to and direct sexualized behaviors toward their therapists, such as suggestive looks or teasing. This should come as no surprise given the intimate nature of psychotherapy. Such powerful feelings can be experienced as love or something like it, although they may be based more on the therapeutic context as opposed to the therapist as a specific person. So, in a survey of female psychologists, almost half reported sexualized behavior emanating from their male and less often female clients. The younger the therapist, the more likely the perceived sexualized behavior directed toward them. So there are so we have here three components according to Hartel, Zeiss, Marino, Rajev, and Leontes that require internal processing when a client expresses attraction in an appropriate way. First, how does the therapist interpret the meaning of the client's behavior? Was it intentional? Was it perhaps an attempt to control, seduce, or dominate? If it seemed to be unintentional, was the client trying to affiliate or bond? Second, how does the therapist view his or her part in bringing this on? What role did he or she play that may have elicited this behavior? Might a joke or offhanded comment have prompted inappropriate behavior? And lastly, what was the therapist's own internal emotional response? Did it feel flattering, bewildering, annoying, or disgusting? Other contextual variables also need to be considered before making the appropriate response, such as the personal styles of both client and therapist and the duration and purpose of therapy. So what if the therapist also harbors unspoken sexual feelings toward the client, who has now openly disclosed attraction to the therapist? In attempt to better understand such a situation, Goodyear and Shoemate simulated therapy sessions portraying a client disclosing a sexual interest in a therapist. These sessions were rated by groups of therapists. So, ayun. The portrayal of the therapist who disclosed reciprocal attraction was seen as less therapeutic for the client and less skillful than was a condition in which the therapist remained non-committal. So, we have here a case, a sample case also. So although you can read this, although the actual therapist on whom we based this case never engaged in sexual relations with the client, he suffered a highly publicized licensing board hearing that resulted in sanctions for continuing to treat a client whose pathology fell well beyond his level of competence. We acknowledge that the close and intimate nature of psychotherapy can result in a special kind of caring between clients and therapists. It is important to attempt to differentiate caring, positive feelings toward clients from what Gelso and his colleagues referred to as conflict-based sexual feelings emanating from the transference and counter-transference experience. So, ayun, that's the explanation. So, physically touching clients. So, touch can come across in many ways. It is an intensely intimate, complex mode of communication to convey support, consolation, empathy, caring, and sincere concern. Touch can also signal sexuality or elicit anxiety, aggression, and fear. So, the relationship between the toucher and the touchy and how and where each party is being touched can create complicated ethical dilemmas for everyone, including therapists. Whereas boundaries violated in the extreme are unanimously viewed as unethical, far more variability of opinion pertains to the use of touch in psychotherapy. Yan. Non-erotic touching. So historically, the laying on of hands has been an integral part of the healing process. The calming and attendant physical benefits of supportive stroking during childbirth and massage for relief from a wide variety of physical ailments and emotional disorders have been repeatedly demonstrated. Indeed, massage as therapy predates recorded history, and drubbing was a major from medicine until the advent of pharmaceuticals in the 1940s. It would seem then that appropriate touching should be an integral procedure in mainstream psychotherapy. According to Zur, touch in psychotherapy is the most controversial of all boundary crossings, largely because both culturally and professionally touch is associated with sex. So, the topic in general provokes anxiety and confusion. When therapists do touch clients, the circumstances most frequently considered appropriate include expressions of emotional support and reassurance, or during initial greeting or closing of sessions. Children and the distressed or depressed may benefit from appropriate touch. Very brief, non-erotic touching on the hand, back, and shoulders involves the safest areas of touch and can still convey a compassionate, supportive massage. So, ayun. A survey of clients who experienced touch by their therapists reported a low incidence of negative reactions to non-erotic touch and the high incidence of positive reactions, such as facilitating trust and feelings of acceptance, creating greater openness with their therapist, and enhancing self-esteem. So, clients may initiate touching because of a desire to be physically close to their therapist. And it's the therapist's decision to touch or not to touch must often be made quickly. So we have here a sample case of Janet Demure, where she complained to an ethics committee that her therapist, Patton Strokem, a PsyD, behaved in a sexually provocative manner which caused her considerable stress and embarrassment. He allegedly put his arm around her often, massaged her back and shoulders, and leered at her. Dr. Strokem was shocked on learning of the charges and vehemently denied any improper intentions. He claimed he often put his hand briefly on client's back and patted or moved his hand with the intention of communicating warmth and acceptance. His customary constant eye contact was his way to communicate that clients had his full attention. He admitted that Demure seemed uneasy but expected this would quickly pass, as it did with others who were not used to such expression of caring. So Dr. Strokem's training as a humanistically oriented practitioner disposed him to considerable non-erotic touching of clients. Regardless of the therapeutic orientation, however, it is necessary to remain aware of individual clients and their special needs, issues, and a sensitivity that may well require an alteration in one's usual demeanor. Cultural factors regarding touching, traditions, and tolerances must also be taken into consideration. For some clients, touching can be poorly tolerated under any circumstances. So, ayun. Sometimes clients might misunderstood or misinterpret sometimes the therapist. So it really happens. So we have here kissing, romancing, and casually dating clients. So there is a letter written by Sigmund Freud, which is shown here. It's a slide. In 1931, he wrote this letter to his disciple, Sandor Ferenczi. Reveals how sexual innuendo in therapy was brewing almost 90 years ago. Ferenczi suggested that showing physical affection to patients might assist in neutralizing early emotional deprivation. Freud responded, so ito yung sinulat niya. You have not made a secret of the fact that you kiss your patients and let them kiss you. Now I am assuredly not one of those who from prudishness or from consideration of bourgeois convention would condemn little erotic gratifications of this kind. But that does not alter the fact that with us, a kiss signifies a certain erotic intimacy. Now, picture what will be the result of publishing your technique. A number of independent thinkers will say to themselves, why stop at a kiss? Certainly, one gets further when one adopts pawing as well, which after all doesn't make a baby. And then bolder ones will come along who will go further to peeping and showing, and soon we shall have accepted in the technique of analysis the whole repertoire of demi-viguerie and petting parties, resulting in an enormous interest in psychoanalysis among both analysts and patients. So, was Freud correct in suggesting that therapists who touch and kiss clients are also more likely to have sexual relationship with them? So, once certain boundaries are crossed, a slippery slope does appear to exist. Critics of the slippery slope argument suggest such thinking is a holdover from rigid psychoanalytic theory that sexualized any rule crossing. So for you guys, was Freud really correct in suggesting na yung mga therapist na hinahawakan or kinikiss yung clients, parang meron ba silang relationship, sexual relationship, or possible ba na magkaroon ng sexual relationship sa with the client? So, ayun. Next. So, Gottlieb and Jungren rightly pointed out that it is unlikely that all therapists are vulnerable to a slippery slope leading to sex with their clients. But we would argue that once behaviors routinely associated with dating and courtship rituals are inserted into the therapy relationship, the slope is sheer and slick. Although courtship style behaviors are not classified as sexual intimacies, casual social excursions outside the office become risky because they typically involve personal self-disclosure and other behaviors leading to misunderstanding or confusion in clients. Even with no therapist motivations beyond platonic pleasantries, the next case describes how things go wrong. So, we have here the case. Ayan. Willie Inchworm was attracted to Selma Receptive, his client of several months. Selma readily accepted what Dr. Inchworm believed at the time to be a professionally appropriate invitation to attend a lecture on eating disorders. Given that Selma's sister had a history of anorexia nervosa, the lecture concluded at 5 p.m. So Dr. Inchworm invited Miss Receptive to stop for a bite at a nearby bistro. The next week, Inchworm accepted Receptive's gift of a book written by the speaker from the previous week. The following week, Inchworm agreed to a reciprocal dinner at Receptive's apartment. Afterward, as they enjoyed a third glass of wine, they looked into each other's eyes, embraced, kissed for a while, and retreated into the bedroom. So, it does not take a clairvoyant to predict such an outcome. In this actual case, an affair persisted for a few weeks. In the meantime, the therapist met someone else of more interest to him. When the client was told they would no longer be seeing each other outside of therapy, she expressed considerable anger toward him. In response, Inchworm terminated the therapy. The client sought and won a large damage award through a civil malpractice complaint. So, ayun. Next, sexually intimate behavior with clients. So, clients new to therapy are unsure of what to expect. They place their trust in someone they believe possesses highly specialized skills and who is being paid to act only in their best interests. In addition, clients usually come into therapy with vulnerabilities and likely feel in a one-down position as they walk through the door. So the American Psychological Association, or APA, did not adopt a prohibition against sexual intimacies with clients until 1977. Yet, even prior to the late 1970s, sex with clients was generally viewed as poor professional practice, a dual-role relationship, and likely to be exploitative. Today, all major mental health professional codes have clear prohibitions against engaging in sexual behavior with current clients. So, next. Incidence. It is difficult to estimate accurately the frequency of sexual intimacies between psychotherapists and their clients. So, anonymous self-report surveys, even if we assume that none who did not return their survey forms had been sexually intimate with clients, revealed that far more therapists engage in sexual behavior than is ever reported to ethics committees and state licensing board. Early survey data indicated that as many as 26% of male and 3% of female therapists acknowledged engaging in sexual intimacies with their clients. Another survey revealed no significant differences across psychiatry, social work, and psychology in the rates of self-reported sexual relationships. So who is responsible? In interviews by Sommer and Seidon, almost one-fourth of clients who claimed to have had sexual relations with their therapists admitted that they initiated the first embrace. Some clients may actively, knowingly contribute to the creation of sexually tempting atmosphere in the therapy setting. Ethic committees and other hearing panels are not impressed by the admission, kumbaga, yung pag-confess. However, when therapists whine about being lured and snared as defenseless victims of beguiling clients. So, we have here a case. Hapbao Lover wrote a letter in response to an ethics committee inquiry insisting he was worn down by a client who showed up wearing dresses with the neckline and the hemline, almost meeting and started flirting with me the minute she walked into my office. He was convinced that she set a trap for him. So such excuses surface more often than you might think. Some commentators seem sympathetic toward therapists who, as Wright contended, are enticed into lustful moments by unscrupulous clients seeking to exploit their therapist's weaknesses. Nevertheless, shifting blame or responsibility to the client, even one who is adeptly manipulative or seductive, is never an excuse for incompetent, unprofessional behavior. The obligation to uphold ethical, legal, and professional standards is not a duty to be evaded, excused, or assigned to clients. Ayun. So, harms to clients. When sex enters into therapy, a helping environment has been shattered. So, early surveys of psychologists Holroyd and Brodsky and psychiatrists Gardner revealed doubts that erotic contact or sexual intercourse with clients could be beneficial and sometimes compared such as acts to rape or incest. Indeed, one of the most unsettling research findings to date is that adult survivors of familial incest are at especially high risk of subsequent sexual abuse by their therapist. Available evidence confirms that harmful and exploitative impact of sexual activity with clients due to abuse of power, mishandling of the transference, relationship, role, confusion, and other factors pertaining to the clients as individuals. Available, oh no, sorry. Although some may quibble about the quality of research of the generalizability of the findings, such debates obscure the basic point that sex with clients is unethical and lies well outside accepted standards of care. So, some clients may view sexual relationships with therapists as pleasurable in the beginning, or at least shield the abusive features that later come to view them as exploitative. Yeah. So next, who engages in sexual relations with clients? Mental health professionals themselves may puzzle over how intelligent, educated men and women living in a world of carnal opportunity could be so stupid that they engage in behaviors that are blatantly unprofessional and dangerous to their clients as well as to themselves. We may also assume that therapists found guilty of sexual intimacies with clients consist chiefly of the poorly trained, obtuse, seriously disturbed, or psychopathic. Amazingly, actual cases from our personal knowledge include a past president of a state psychological association, current and former members of state licensing boards, a professor at a major university who authored an article on professional ethics, a chair of a state psychological association ethics committee, and even an author of an article condemning sex with clients. No one appears to be fully immune from temptation or the potential to be exploitative. So, ayun. Common offender characteristics. Available reports suggest that therapists who engage in sexual intimacies with clients are likely to have one or more personal issues or characteristics. This include feelings of vulnerability, fear of intimacy, crisis in their own personal sex, love, or family relationships, feelings of failure as professionals or as individuals, high needs for affection, positive regard or power, idealizing a special client, poor impulse control, and an inability to set limits, feeling depressed or burned out, social isolation, overvaluation of their abilities to heal, isolation from peer support, sexual identity, and other unresolved conflicts, diagnosis for a depressive or bipolar disorder, narcissistic, sadistic, and other character or predatory psychopathologies, and insufficient training. Offending therapists also tend to have strong denial or rationalization defenses in place, are more likely to engage in rescue fantasies, have a family history of sanctioned boundary transgressions, and are intolerant of negative transference. They are more likely to work alone. They often deny to themselves that their behavior has any adverse impact on clients, and are deficient in their ability to emphasize. Most sexualized relationships apparently do not last long. Even among those not formally complained against, about half the time such affairs were judged into retrospect as not worth having. So, the most common offender is a male in his 40s or 50s, as expected, and around 15 years older than the clients the offender beds. Middle-aged therapists going through a divorce or having other problems in a primary relationship should remain alert because the risk of over-involvement with clients is exceptionally high. Some abusing male therapists may have themselves experienced sexual abuse as children. So, ayun, pwede pala yun. Well, you can watch, parang nakikita nyo naman yun sa movies na may mga tao na they're abusive dahil sa mga past experiences nila. So, in therapists, it could happen. So, clients exploited by their therapists are mostly younger women. Perhaps as many as 5% are minors at the time of the sexual activity. And almost a third have been victims of incest or physical abuse as children. Homosexual clients of either sex with the same-sex therapist appear to belong to the next most frequent category. So, we have here a sample case about Samuel Sorry, a counselor in his late 40s, explained to an ethics committee how his sexual relationship with a 26-year-old client was sparked primarily by a series of rapidly accelerating crises in his personal life. His wife of 25 years left him for another woman. He and his best friend had a falling out, and his father recently passed away. He was feeling lost and saw himself as a failure. His young client was trusting and complimentary, and his exact words, "She was the only thing in my life I look forward to." That most clients who become involved in sexual intimacies with male therapists tend to be younger. Females suggests that sexually exploitative male therapists may view such women as sources of as if intimacy or as a means to recapture waning youth and virility. So, next. Less common offender scenarios. So, only rare case appears driven by therapists' premeditated attempt to exploit, such as the counselor who hypnotized clients for the purpose of getting them to masturbate in his presence, or the psychologist who had sexual relationships with the three most intriguing of his dissociative clients. 16 personalities. These acts are apparently and thankfully exceedingly rare. So, a somewhat more frequent scenario is an attempt by the therapist either to consciously manipulate or to rationalize sexuality as a legitimate component of therapy. They convince themselves that they are genuinely charitable by offering clients something special to alleviate their problems. Rescue fantasies are also common in this group. Again, such therapists often have little insight into the self-serving nature of their actions. So we have here another case about John Bestman convinced Marsha Willing that a therapist was the perfect person with whom to have sexual affair because no one else could better understand her needs or be as trustworthy. The client found Mr. Bestman a mediocre lover, and the therapy became confusing and somewhat disgusting to her. She contacted an ethics committee. We also know of cases in which the therapists invented specialized techniques built around sexual exploitation. Again, these examples are scarce but highly visible because they attract media exposure. So, moving on is Kuya Carlito. So, that will be my part. So, thank you and sorry for my voice.